Hola, buenos días a todos. ¿Ya traen su cafecito y todo? Well, good morning, everybody. I'm great to see so many incredible voices here in the room today. My name is Alberto González. I'm a senior advisor for external engagement at the USDA's Food and Nutrition Service, and I will be today's moderator. I'm happy to be today's moderator for this important session, our plenary on 2023 federal and state policies and improving public health. So I'm thrilled to be here with all of you this morning with the National Hispanic Medical Association. I had the opportunity to meet a few of the attendees yesterday during the reception and was just very inspired and motivated just to hear about your stories, but also about the work that you do, especially regarding the last few years that's been challenging with COVID and how that's impacted our respective communities. So I have the pleasure to be moderating today's conversation about state policies and improving public health. So for those of you who may not know, at FNS, which is the agency I work at under the USDA, we administer a suite of more than 16 federal nutrition assistance programs that reach 1 in 4 Americans over the course of a year that have been proven to reduce food insecurity, improve health outcomes, and reduce healthcare costs. And these include our powerful public health nutrition programs like WIC, which reaches millions of Americans, including our parents, infants, and children, or our padres, niños, y bebés, every month. And if you haven't already, I encourage you all to stop by the USDA's WIC exhibit here at the conference to learn more about this powerful program that is helping to advance health equity in the Latino community. My colleagues with the WIC team, can you raise your hands? So please be sure to visit the table at the exhibit to learn more about this incredible program. So now today I'm joined on this stage by 3 powerful individuals in the public health space. I'm going to briefly introduce them as they will share more about their exciting work during their remarks. I have Charmaine Davis, who's the Director of Regional Programs and Operations at the Women's Bureau with the Department of Labor. We also have with us today Dr. Geraldine Luna, who is the Medical Director at the Chicago Department of Public Health, which is right here in the city. And last but not least, we have Kaitlyn Saal-Ridpath, who is the Senior Director of Policy and Research at Better Medicare Alliance. And then before we pivot to audience Q&A and close out today's session, I will also be sharing with you the exciting work that the U.S. Department of Agriculture is leading to help advance food and nutrition security and steps you all can take to help us advance the Biden-Harris administration's national strategy on hunger, nutrition, and health. So at this time, I will turn it over to Charmaine Davis to share with us her work at the Department of Labor.
Good morning, everyone. Do I just click to go to my slide deck? There we go. All right, good morning, everyone. Again, my name is Charmaine Davis. I serve as the Director of Regional Programs and Operations for the U.S. Department of Labor's Women's Bureau. And I know that many of you may not be familiar with the Women's Bureau, so I'll tell you a little bit about the agency before I really delve into the bulk of my presentation. So the Women's Bureau, we are one of the oldest agencies within the U.S. Department of Labor. We were established by Congress on June 5th of 1920 to formulate standards and policies that would promote the welfare of wage-earning women. And we at the Women's Bureau, we recognize and we understand that it's important, it's almost essential to have good workplace policies in order to promote the welfare and the health of working women, but just all workers in general. In 2020, data collected by the CDC found that the U.S. has the highest rate of maternal mortality rates amongst industrialized nations. And research has let us know that proper prenatal care and proper medical management of chronic conditions like diabetes and high blood pressure could significantly help to reduce maternal mortality rates. And so in order for workers and individuals to be able to properly manage those conditions like diabetes and high blood pressure, they need to have access to paid, job-protected, paid time off. And so that's why the Women's Bureau is really working to expand access to paid leave for workers. But again, before I get into the many workplace policies that are necessary for workers to manage their health well and just to ensure that we as the Women's Bureau are promoting the welfare of workers, I want to back up and just give you a larger overview of who the Women's Bureau is. So, as I said, the Women's Bureau is one of the oldest agencies within the U.S. Department of Labor. I like to think of us as the voice of working women within the federal government, that we are advocating constantly and making sure that we're centering working women in our policies and practices. And the Women's Bureau, we fulfill our mission through research and policy analysis, public education, and through our grant funding that we provide through our 2 flagship grants. Our WANTO grant, which stands for Women and Apprenticeships and Non-Traditional Occupations. That grant funding funds organizations that are creating pathways for women to enter into non-traditional occupations where women tend to be the minority, and apprenticeship programs. And then we have our FAIR grant, which is our Fostering Access, Rights, and Equity grant. And that helps to fund organizations that are educating workers on what their rights are in the workplace. So those are the 3 ways that the Women's Bureau fulfills our mission. I now want to share with you our priority areas and just talk with you about how our priority areas connect with us promoting the welfare and health of workers. So our first priority area is getting more women in pathways to high-wage jobs. We know, I think all of us know, that financial instability can cause a lot of stress in a worker and individual's life, and we know the negative impact that stress can have on a person's health. And so the Women's Bureau, we're working to create those pathways through job readiness trainings and other preparations such as apprenticeships so that women can enter into higher paying jobs. We know through research that women are concentrated in lower wage jobs. Of the top 25 jobs that women are the majority, 18 of those 25 jobs pay less than the average wage. So this is why it's a priority for the Women's Bureau that we're doing what is necessary to equip women to compete for those higher paying jobs. Our second priority area is ensuring workers know and can exercise their rights in the workplace. The Women's Bureau also recognizes that workers who come from historically marginalized communities, such as women workers, workers of color, justice-involved workers, undocumented workers, LGBTQ workers, are more vulnerable to exploitation and labor violations in the workplace. And so this is why we're very intentional about doing outreach to lead Know Your Rights workshops with these different demographics. It's also important for us at the Women's Bureau to prioritize these Know Your Right trainings because we know that, sadly, nearly 5,000 workers are killed on the job each year. And we know that Black and brown workers have a higher risk of injury on the job because they're more likely to be placed in hazardous and dangerous jobs. So we want those workers to know what labor rights and protections they have so that if there are OSHA violations on their job, they can immediately speak up and the Department of Labor can come in and investigate in order to ensure that those labor violations don't continue. Our third priority area is eliminating pay inequity and gender-based discrimination and harassment in the workplace. And so when it comes to the gender wage gap, we also know that that is deeply felt by women of color. So Black women on average are paid just 63% of what their white male counterparts are paid, and Latinas on average are paid 57 cents or 57% of what their white male counterparts are made. It's really important for us at the Women's Bureau to see that gender wage gap close because we know that the amount of money that a worker makes over their career, it impacts their financial condition and position when they retire. So women are significantly more likely to retire into poverty. And if you're retiring into poverty, that means that you're less likely to have access to the resources that you need to properly care for yourself as you age. And so that's one of the many reasons why the Women's Bureau has prioritized closing that gender and racial wage gap. Our fourth priority area is improving pay and working conditions in key female-dominated sectors. So again, as I was saying before, women are highly concentrated and overrepresented in low-paying jobs. A clear example of that is the fact that child care workers, over 90% of them are women, and many of them are women of color. And yet the average child care worker is earning less than $30,000 a year. Now, child care workers, we know that that job is extremely important. For many of us, if it's not for child care workers, we could not go to our jobs because you need someone who's taking care of your children. We also know that those child care workers are caring for children during their formative years. So it's a very important job. But the sector is highly concentrated with women, and it's a very low-paying sector. And so the Women's Bureau is working to increase the wages and benefits of child care workers and other industries where women are concentrated in. But we also want to be mindful that as child care workers' wages increase, that families don't bear that burden alone to help supplement the income. So we're working and thinking through what those solutions could look like. Our fifth priority area is expanding access to paid leave and quality and affordable child care and elder care. So less than 25% of workers in the private sector have access to job-protected paid family leave. Among the lowest wage workers, who are predominantly women and people of color, 95% have no access to job-protected paid family leave. And as I was saying at the beginning of the presentation, in order for you to be able to go to your doctor and properly manage your health and take care of some of those chronic conditions that can lead to very negative health outcomes, you need to be able to have the time off to be able to do that. We also know that when workers don't have access to paid leave, it creates what the Women's Bureau calls caregiver penalties. We understand that women take on so many of the caregiving responsibilities in their families, and when you don't have access to paid leave on your job, that might work for you if you are a single woman with no children, because maybe if you get sick, you can kind of press through it, even though that is still not ideal. But when you're caring for children, when you're caring for an elderly parent, when you have a spouse that may be sick, that you might need to care for, not having access to paid leave imposes a huge penalty on you as a worker. And so we at the Women's Bureau were working to address some of those caregiver penalties so that workers and individuals don't feel that they're being penalized on their job simply because they're caring for a child, a spouse, or a parent. So I want to talk more about paid leave and that benefit and just all the positive impacts that it has when workers do have access to job-protected paid family leave. So here are some of the things that I just want to highlight. Paid maternity leave improves the maternal and infant health, including physical health and well-being. Increases of paid maternal and parental, maternal, and paternal leave decreases rates of infant mortality. Paid leave has reduced the incidence of head trauma caused by abuse among children less than 2 years old due to lowering stress levels of the parents. One study found that the introduction of paid maternity leave in 5 states, California, Hawaii, New Jersey, New York, and Rhode Island, led to a reduction in low birth rate and preterm births, especially for Black and brown mothers. Every additional week of paid leave a mother takes reduces the likelihood of reporting poor mental wellness by 2%. And longer paid leave significantly increases breastfeeding, initiation, and duration, which has innumerable benefits for moms and babies, including improving the function of the digestive and immune system of the child. And the National Partnership also reported that among heterosexual couples, paid leave for fathers can improve their engagement with the infant, decrease the intensity of depressive symptoms in the mother, and improve the child's overall development. And so again, I could go on and on about the benefits of parents and workers having access to paid leave, but I do want to shift and talk about some of the consequences that workers experience, some of those negative impacts of not having access to paid leave. So the following is true of new mothers without access to paid leave. Their chances of being rehospitalized after giving birth is almost 51% higher than mothers with paid leave. The likelihood of their infants being rehospitalized in the first year is about 47% higher than mothers with paid leave, and they are almost half as likely to have success in managing stress and engaging in regular exercise after birth than mothers with paid leave. And so I just want to close by saying that the Women's Bureau wants to be a resource to medical professionals and workers and letting them know what rights and protections they have. Recently, the Women's Bureau, we worked with doulas in Birmingham, Alabama, and in Connecticut, and we were training them on FMLA and paid leave policies so that when they're working with their clients, they can educate them if they're having any struggles or concerns about needing extended time off. And we want to be able to do the same thing with doctors and other medical professionals, just so that if For example, I know when my father was diagnosed with cancer, my mother, she was working full time. And so she needed to know that she had job protected leave available to her because of FMLA, the Family Medical Leave Act, so that she could take that time off to be with my father as he was going through chemotherapy treatments. We want medical professionals to be able to suggest those type of things to their patients because it makes a huge difference. Sometimes you can't even think clearly and process things when you're dealing with those type of diagnoses, and just to have someone to prompt and remind you these things are available for you to utilize. So this is why the Women's Bureau wants to make ourselves very accessible to all of you in this room, and we would love for you to share with others that we are a resource within federal government, and I'll be putting some of our handouts on the back table if you want to pick those up. Thank you.
Thank you so much, Charmaine, for your presentation and the important resources that you all have to offer to this audience. I realized that I skipped over an important slide earlier, so I wanted to just share with you all this slide here on the learner notification that provides some background on the credit for this presentation. And then just to let you all know that this session speakers have no actual or potential conflict of interest in relation to this program and/or presentation. And lastly, just wanted to recap the objectives for today's plenary, which is to learn about federal government and state-level social and healthcare safety net programs, including nutrition assistance programs, along with identifying successes and opportunities for improving public health. So you heard from our first speaker from the Department of Labor talk about their work with the Women's Bureau, and I will now turn it over to our next speaker, who's a local leader, Dr. Jerry Luna.
Ooh, okay. We didn't have a bench here, but we'll make it work. So, my name is Dr. Geraldine Luna, and I'm Medical Director of the Chicago Department of Public Health in the Equity Bureau. I started as a COVID-19 response from the department, and these were very challenging times. So how has COVID-19 or a public health emergency shaped the way that we approach our problems here in Chicago? It's changed dramatically. So let me just walk you through our history. We're looking at no scaffolding. We want to make permanent changes the way that we approach public health here in Chicago and the health departments. It's been lots of conversations happening from federal, from state, and local level. For example, here in Chicago, or the money that we manage, and this is just to give you an example of the budget, only 15% of our money goes to what is public health. So as you can see, hospital care, including reactive care, 31%, physicians and clinical, and only that 17%, it's what goes directly into public health. From that 17%, only a 5% is directed to public health. So that leaves significant gap. We're talking about underfunded, understaffed department, which should carry all these emergencies, approaches, containment, and connect our individuals with chronic conditions and improve overall health and well-being of our Chicagoans. So what happened in 2020? And this is where everything came to crumble, the way that we were approaching things and understanding more of our communities. In my case, I want to speak directly about the Latinx community, which we're changing from Latinx pretty soon as well. So everything became very public. I am the first medical director to go to the Chicago Department of Public Health. We never had a Latino doctor, a Latina in this case. So it's incredible how underrepresentation can be part of the problems and now part of our solutions. So when we're talking about life expectancy, and this is how we move to Healthier Chicago 2025, we have the representation of our population mix here, and this is where we start. This is in 2012. Look at the trajectory, how has that been declining for Latinx communities. We saw something, not significant changes, 2013 to 14, but as we move closer and closer to 2017, we have seen that from 81 years old that our Latino population used to live, now we came down to 80. And that changes dramatically with COVID-19, so I'll show you that so we can compare. So what's driving this gap? And we see it in minorities, segregated, marginalized communities here in Chicago. And we're talking about number one killers, or the first 5 killers as we put it there. Chronic diseases, even during this first year after COVID, continues to be the number one cause of death. We're talking about diabetes, obesity, hypertension, all the killers, pretty much for minority communities, which are Black and browns, and by brown I mean in the majority of Latinx communities. Homicide being the second one, and then we see other conditions, infant mortality, HIV, opioid, and others. And you can see that chronic conditions are pretty much dictated by housing, food access, environment. So there's a lot of community efforts to try to build up and create permanent solutions. Public safety has become the number one issue for this new administration. And we, people that live here in Chicago, knows how we're portraying nationwide. And then neighborhood planning and development. We need collaborative efforts. Human services and public systems need to change. Health equity, we know, affect, and when we're talking about social determinants of health, this is pretty much what we see. This is a map representation, so we can see a little bit of what we're talking about. Obesity, our communities, our neighborhoods from west, southwest, and south are experiencing the highest obesity rates, and not only that, chronic conditions overall. Perceived unsafe neighborhoods. You know that as you go west and south, unfortunately, we see more criminal activities, we see more violence, community, domestic, all of that dictated by social determinants of health. And then food access barriers. This is the way, and we know the south side is the most impacted because we don't have accessibility to not only food, but also to health care, quality care, in this case, transportation, good schooling. So this is what we're facing. And then when we're talking about the influence factors that we see, socio-economical, continues to be 40% of the driving barrier that represents to our communities for well-being, to improve the outcome of health. And then behavioral changes, a lot of things that we're prioritizing and see how we can strategize with our communities. And let me just tell you how we came to the conclusion. The community collaborations is everything to achieve Healthier Chicago 2025. What did we learn from COVID-19? First of all, we know that we were disproportionately affected minorities here. Seeing that the mortality was the highest in Black communities, and then the cases in Latinx were the highest, 3 times the risk of contracting COVID-19 compared to a white community. So there was a disproportionately affection and high hit communities. We assembled the Racial Equity Rapid Response Team, and that started our new journey, in this case, our mission. So when we were looking at the root cause of these disparities that we were seeing, we noticed that in terms of, this is a survey that we did, people losing jobs in COVID-19, people for somehow changing responsibilities, switching families, COVID-19, Latinx community was the most impacted, essential workers, people losing their jobs because of the quality of the nature of their jobs. We are overrepresented in hospitality, services. In the restaurant, you come in there, you'll see our Latino faces are number one, leading and serving the public. Beautiful jobs, but it comes with a price. And then reduction pay, we notice again, Latinx community were leading that reduction in home income. So that was one of the financial devastation of COVID-19 in our communities. When we look at where we were in 2017 that I mentioned, that we had lost already 3 years in life expectancy, when it came to 2019, just a year, Latinx community had the steepest fall in life expectancy. No one else. A Black community had the wider gap in life expectancy with a decline, obviously, but Latinx community had the steepest in just one situation, COVID-19, an emergency, which gives you or portrays you how the future looks for us. Very bleak. And let me just go back very quickly here. And then let me just walk you through what escalated, what increased. Drug overdoses went up 44%, gun-related homicides, 60%, motor vehicle accidents, 54%, diabetes, 36%, alcohol use, 25%, and heart diseases increased. So we were not only devastated that we were dying, getting those cases the highest, but all these other chronic conditions exacerbated with COVID-19. So the way that we look now in 2020 and still look now, heart disease is the #1 killer. COVID became the second cause of death here in Chicago, and cancer #3. Life expectancy by community area, and then you can see the hot spots, those red hot spots is where we saw the lowest, the widest changes in life expectancy with a drop of those happening for those communities. Here in Chicago, we created a COVID and Community Vulnerability Index, and these are the different factors that came into play. Social demographics, uninsured individuals. Unfortunately, of the 10% of uninsured individuals in Chicago, more than 50% are Latinos. And then crowded housing. We know that we have multi-generational housing when we're talking about Latinx communities. And then no primary care provider. When we're talking about epidemics, overrepresentation in people over 65 with all these chronic conditions, smokers and diabetics. Occupational, we saw essential workers came into play, and then we saw how the devastation of being out there in the public without being able to social distance and stay at home had affected our Latinx community. And then the racial morbidity in 2020 compared to 2019, and the COVID burden. And you know how it comes when we're talking about our marginalized, segregated communities of Latinos here in Chicago. So what did we learn? Yes, there was a learning curve here. First of all, those militarized, massive vaccination center when that time came didn't work for Latinx communities. Everything we did hyper-locally was better received, created more trust, and it has to do with the faces that were serving our community, people serving people in the same community. So knocking on the doors with canvassers, sending out promotoras de salud made a huge difference in people to be in a position to receive the information, to get those vaccines that nobody really trusted. And then community members, we had to collaborate with community members, and we had to lift up our organizations, community-based organizations, to contract those, have those phases that people already know, provide vaccines, provide medications, provide all this care to our Latinx community. The other thing that was important is that we created this program, which is pretty much for homebound individuals, but we opened up criteria. Anybody that wanted to receive their vaccines at home could do it for free. And we went there, we incentivized and led it, but unfortunately, Latinos did not really use that much of that service, because having somebody come in, it's not like something that our undocumented population will want to receive in their homes. The government was never welcome, but yet it became better and better, and now #1 users are our Black community and our Latino community. So when we're focusing on the population experiencing homelessness, we started what it's called shielding housing, open hotels, which were devastated by COVID-19. We kind of incentivized or put a little bit, invest money locally, and created those homes for families to isolate, to be there to receive the care. We changed our primary and behavioral health care here in Chicago. In shelters, we went there, we were deployed there. We standardized outreach to encampments, transit, testing. And then isolation and quarantine, we did into this meeting with families and tried to isolate them together, because when we're talking about moms and kids, you can't really separate those. So we try to put together a plan that fit perfectly well to the families living here in Chicago. $89 million has been invested in mental health. And as you can see, the devastation, moving now more than physically, is mental. So now we have 177 clínicas alivio here in Chicago in our 77 communities, where we have language and competence and cultural competency train individuals there, and most importantly, people from their own community, the people's people, providing those services in Spanish and 105 languages that we have. And not only that, but we have migrated into schools. Believe it or not, before COVID, we only had 3 mental health clinics here in Chicago. And now we have 177 clínicas de alivio, which not only is mental health, but also includes other type of crisis. We're talking about if they lose their home, insecurities, nutrition, healthcare. And now we're helping out the transition of individuals, our familias, here in Chicago with promotoras, navigating this call center 211. So I just wanted to mention where the money is going to. And looking ahead, but now we're trying to visualize how we can better our efforts, meet people where they are at. And we're doing that. We divided by equity zones. So this is one of the initial way to approach hyper-locally. So we're calling Healthy Chicago Equity Zones. And we started vaccination by vaccinating individuals, giving testing, and providing medications. But now we have escalated, and now we have the same community-based organizations. We're investing in them to have all other resources for chronic disease, to help with mental care, and to help go to our communities. We're creating these programs where people from those same communities go to their home in the midst of a crisis, dividing what it's policing, that 911 call. Now we have our care team for mental health crisis assisting in 911, and instead of receiving a police, which probably people just, it doesn't really address the issue, we have a special mental health team that goes to their home and rescue our communities. So how we see the future for public health after seeing a public health emergency of this magnitude? Data. Data is everything. And when we started working together, there was a lot of community allies that came to our Department of Health. You're missing all this data. There's immigrants, undocumented, dying at home, which we're not really registering as those dead for Latinos. Preparedness and accessibility. We know now the importance of hyper-local approach and working in collaboration with those community members embedded, that they know the lay of the land for the communities that they serve. Or coordination and communication, creating systems of care beyond the clinics. We want to meet the people where they are at. And this is the way we can do it and build and strengthen our community. And it's all about trust. So that's the end of.
Thank you so much, Dr. Luna, for your leadership to keep all Chicagoans healthy, especially appreciated hearing about your work to reach the Latino community here. So let's continue this important conversation by having Kaitlyn come up from Better Medicare Advantage to talk about her work.
Good morning, everyone. My name is Kaitlyn Saal-Ridpath, and I am the Senior Director of Policy and Research at the Better Medicare Alliance. I just want to first say thank you to NHMA as well as the organizers here, as I'm very grateful for this opportunity to speak with you today. Unlike all of you, I am not a clinician, but I do have a deep background in public health with a focus on the laws and policies that influence health outcomes. So just a brief overview of some of the objectives as well as disclosures. I think these align very nicely with what we laid out earlier, so just keep moving. And then just a little bit more about my organization. Who is Better Medicare Alliance? We are the leading research and advocacy organization supporting Medicare Advantage. We are a community of over 200 ally organizations from across the healthcare spectrum, which also includes 1 million beneficiary advocates. And so our alliance includes community organizations, providers, including groups and associations just like NHMA, as well as health plans, aging service organizations, and more. And so together, we share a deep commitment to ensuring that Medicare Advantage remains a high-quality, cost-effective option for current and future Medicare beneficiaries. Now, what is Medicare Advantage? And you might be thinking about, why am I talking about this? Because within the next few years, the majority of Medicare beneficiaries will choose Medicare Advantage, meaning there's an opportunity to shape and influence and improve the health and well-being of a growing population. MA is the managed care or the public-private partnership option available to individuals eligible for Medicare. Within Medicare Advantage, also known as Part C, this includes the coverage of benefits and services that are within Parts A and B. And so the Centers for Medicare and Medicaid Services pays health plans a risk-adjusted and capitated payment each month to deliver all the healthcare services to enrollees. So at its foundation, Medicare Advantage is designed for delivering patient-centered, value-based care, which is a topic that we've heard a lot about over the course of this conference. Most plans also include prescription drug coverage. In fact, 89% of Medicare Advantage plans offered this year include prescription drug coverage, and access to these plans is nearly universal, with 99% of all Medicare beneficiaries having the option of choosing this type of plan. One of the things that sets Medicare Advantage apart from fee-for-service Medicare is the ability to offer supplemental benefits. I'll touch on this more shortly, but to preview, supplemental benefits may come in a few forms, including lower cost sharing for enrollees, expanded Medicare-covered benefits and services, and what people might typically think of, these extra benefits that are not otherwise covered by fee-for-service Medicare. Examples of this include things like dental, hearing, and vision coverage. But more recently, these additional benefits and services tend to be more social needs related. And so looking now to the MA population as this program continues to grow, there are over 31 million beneficiaries in Medicare Advantage today. To put this in context, the overall Medicare population is around 65.5 million people, meaning 46% of all Medicare beneficiaries are choosing Medicare Advantage. Historically, there's been a narrative that Medicare Advantage is chosen by beneficiaries with high incomes and who are predominantly white. However, the data tells us that this is not the current state of the population. Today, a majority of beneficiaries live on incomes at 200% or below the federal poverty level annually, which equates to about $25,000. For comparison, 36% of beneficiaries in fee-for-service Medicare live on incomes at 200% or below. Moreover, Black, Latino, and Asian and Pacific Islander beneficiaries are more likely to enroll in Medicare Advantage than white beneficiaries, with 60% of Medicare-eligible Latinos choosing Medicare Advantage. It is also uniquely positioned to address the complex medical and social needs that many beneficiaries who are dually eligible for both Medicare and Medicaid may have. In MA, there's an integrated or coordinated health plan that many duals choose to enroll in. And then this is just a snapshot of some of that data I just shared. When you look at the enrollment in Medicare Advantage by race and ethnicity, you see, again, that the Latino, Black, and Asian, as well as Pacific Islander communities are choosing MA at a higher rate than white beneficiaries. Now looking to the dual eligibility status. And so there are two types of dual eligible beneficiaries for purposes of the types of services and cost-sharing protections they receive. You have a full dual beneficiary where you receive full Medicaid benefits as well as the long-term services and supports that come with that, as well as cost-sharing and premium assistance found in Medicare. You then also have partial duals who do not get the full Medicaid benefit, but they do have some of the cost-sharing and premium assistance. Now, I make this distinction because, again, you have access to a wider range of Medicaid benefits as a full dual. Nevertheless, the differences in the medical and social complexity between a full dual and a partial dual is not that big. And so this is an opportunity for Medicare Advantage to fill the gap and offer more robust benefits and services, especially those that are more social needs related, like food and nutrition, non-medical transportation, and housing supports. And so with Medicare being a highly regulated program, the question is then, well, how do stakeholders then actually do this work? And right now, I'll be talking predominantly about health plans, as they are the first source for coordinating and delivering this care for beneficiaries through their provider networks and their community partnerships. But I wanted to also recognize that using these flexibilities and these authorities is not, it won't fully address the issue here and some of the challenges that we have. It is just merely part of the solution. And so just going over some of these flexibilities and authorities that enable health plans to work with their partners to address social needs. This is just a cursory approach, but overall, it'll offer a preliminary understanding of how this public-private partnership really is able to deliver community health interventions as a way to improve outcomes. And so I think it is important, as we've heard earlier just now, that we have to level set a little bit and recognize that COVID was a catalyst for some of this work, but that also many of these flexibilities predate COVID-19 and the public health emergency. So first, we have the Innovation Center within CMS, which was created by the Affordable Care Act and tests innovative healthcare payment and delivery systems across Medicare, Medicaid, and CHIP. There's one model specific to Medicare Advantage called the Value-Based Insurance Design Program, or VBID, and that was implemented in 2017 and just recently extended through 2030. The Innovation Center is testing a range of changes aimed at addressing health-related social needs and advancing health equity and improving care coordination. So for purposes of this conversation, there are additional flexibilities now through the VBID model that allow health plans, along with their providers and community partners, to address the social needs of these beneficiaries. Next, CMS has expanded the definition of primarily health-related benefits and also relaxed the uniform requirement in 2018, meaning the type of supplemental benefits offered and how these could be expanded to include things like in-home support services as well as caregiver supports. Lastly, in 2018, the Chronic Care Act was which was passed as part of the Bipartisan Budget Act, created a new category of supplemental benefits called SSBCI, or the Special Supplemental Benefits for the Chronically Ill. And these were allowed by health plans in 2020 to begin offering benefits and services that are more traditionally social needs related. The beneficiaries eligible for this, they have to have a complex chronic condition that is either life-threatening or could significantly impact their health or function. And so there are a few other boxes to tick here, including high risk of hospitalization, but we know chronic conditions like diabetes fall squarely within this category. And so example of these offerings include, again, food and produce, as well as transportation and general supports for living, such as assistance with rent or being able to subsidize utilities like gas, water, electric, things like that, in addition to social isolation programs. So together, we're seeing this renewed integration of medical and non-medical services to address SDOH through these various flexibilities and innovations developed to improve health outcomes. So then coupled with the aspects that make MA a popular choice among Medicare beneficiaries, such as value-based care, a focus on primary care teams, coordinated care, and these flexibilities in benefit design, we think that MA is well positioned to address many of these needs for both the individual and the community they live in. So then just briefly, as a result of this increased flexibility with supplemental benefits, plans have really ramped up their activity in this space, especially with these addressing more of the social needs. And so we're seeing increased investments primarily in 3 areas for a few reasons. First, these are issues that CMS is specifically focused on, and also working with stakeholders to better understand the activity occurring here. And then second, the data supports the need to intervene. So nearly a fifth of MA beneficiaries experience food insecurity, and almost a quarter rent their home rather than own their home. And lastly, a report released just this week by the Robert Wood Johnson Foundation, as well as the Urban Institute, finds that more than 1 in 5 adults have a transportation barrier that impacts them receiving healthcare services. And so these investments include things like infrastructure, technology and software, platforms, as well as some personnel. So just looking over to the left of this slide, we see some of the changes from last year to this year in plan offerings. I won't go through all of them, but again, we're seeing increases in food and produce, nutrition, transportation, general supports, things like that. But then it's also important to think about how many lives are actually covered rather than just the % of increase in offerings. And so for food and nutrition, nearly 6 million lives are covered, as well as 2.7 million in transportation and almost 3 million in general supports, as an example. But this is also not the full picture, because this is analysis of just the SSBCI benefits that I was just speaking about. So there are other pathways and authorities outside of this, and even Medicare as a whole, that make available resources to beneficiaries to address their needs. And then lastly, and I think most importantly, is the value and necessity of community partnerships, because none of this would be possible without it. I'm a firm believer that healthcare, and specifically health plans, should not be recreating the wheel here, but really acting as a facilitator or a convener to bring these resources and community experts together while supporting them by offering a range of knowledge, resources, and expertises when needed. And we've definitely heard about how important community partnerships are just this morning. And so at the end of the day, there's a shared goal of delivering high quality, person-centered, as well as affordable care that keeps patients healthy and in the home. And then when I was first thinking about my remarks here and what I wanted to share, there were a lot of possibilities, but I then read the theme for this conference and it became pretty clear. From awareness to action and outcomes, finding solutions through innovative approaches. And I think that this is a really fitting theme as it relates to the work that my organization has done and carried out. And so in partnership with NORC at the University of Chicago, BMA has examined the innovative approaches to addressing SDOH and Medicare Advantage. And we've also offered a series of policy recommendations to remove some of the barriers that remain and inhibit the activity in this space. So through this research, we found that investments in internal capabilities and partnerships fall into 3 main categories. First is the data source and beneficiary identification for social needs, interventions, and then the subsequent evaluation. And so just to highlight a few of these, to identify the social needs, it's a critical first step because we can't act on what we don't know. Yet this type of data and even understanding based on relationships with these beneficiaries is often limited. And so to fill this gap, innovative approaches, such as integrating SDOH data into clinical data, aggregating data from multiple sources into a singular location to help inform both providers as well as plans of the status and overall risk for the population, as well as working with providers and the American Medical Association to develop Z codes based on SDOH are just a few examples. Next is the intervention itself, and this is where we see a lot of partnerships happening that I previewed. And so, for example, Meals on Wheels, which is also a BMA ally, it's a national organization, but it does rely on its local affiliates as well as its volunteers to carry out their work and work alongside health plans to deliver meals to seniors after, say, a hospital stay or a post-acute setting stay. And so, they're also a regular face for these individuals when their meals are delivered. And so they offer a degree of companionship as well and have an overall look into the home. And with that, they're able to share back potential gaps in care to the health plan as well as services that may need to be addressed. And then finally is the evaluation piece, and efforts including working with software, programs, or platforms to capture the data and analyze it. Everything from referrals to patient experience to outcomes is underway. And so, despite knowing many of these interventions like healthy meals and offering transportation improve health outcomes, through either lived experience or there's evidence with other populations. The actual evidence development as it pertains to the Medicare population is still in the early stages. And so just looking ahead, I think this begs the question, now what? And so for this audience, I really wanted to touch on 3 of these and the role that you as healthcare professionals play in your patients' lives. First is sharing best practices, whether that's in a forum like we have here today, or simply with a colleague in your community. I believe there's really power in sharing this knowledge and your experience with treating and managing this population. Second is developing the research and evidence base. Part of my job is to engage with provider groups and associations and to amplify the research that they've either conducted or work with them to produce and also think about new opportunities and research questions with the goal of showcasing the value of SDOH investments. And then my last closing recommendation, I would say, is for you all to advocate. And I know that's a pretty general term, and it can look a little different for everyone. Whether that's on the local, state, or the federal level, I really do urge you as advocates for your patients and the care that you deliver to share your experiences so that the good work previewed here and that you see on the ground continues well into the future. And with that, these are just additional resources with some of the data that I've captured here in this presentation, and we can certainly make available for you all. So, thank you.
Thank you so much, Kaitlyn, for your incredible work at Better Medicare Alliance. I'm very excited to be in this space just to talk about the connection with food and nutrition and health. And so I'm very excited to talk to you all about the incredible work that the USDA is leading to help advance our food and nutrition security initiative. So I'm going to spend about 10 minutes just talking about our work, and then we'll pivot to an audience Q&A. Does that sound good? Yes, okay, great. So as I mentioned, I'm going to talk a bit about our work to advance food and nutrition security with the goal of providing food for thought on ways that we can do better together. So the USDA recognizes that we have tremendous potential to improve what Americans eat, and our efforts would have a significant impact on reducing diet-related diseases and lowering healthcare spending, as 1 in 4 Americans are served by more than 16 federal nutrition assistance programs across the country. We are also leveraging the momentum of the historic White House Conference on Hunger, Nutrition, and Health that took place last fall that aims to end hunger, improve nutrition and physical activity, and reduce diet-related diseases and disparities by 2030. The Biden-Harris administration published a national strategy on hunger, nutrition, and health the day before the historic conference and shared how non-federal partners collectively made more than $8 billion to advance the conference goals and implement the national strategy. We were thrilled to see several leading healthcare sector organizations, including the National Hispanic Medical Association, pledge to take several new actions by 2024 to strengthen health professionals' education in nutrition. And just last month, the White House celebrated progress to date on a variety of healthcare conference commitments and launched a challenge for us to do more to end hunger and build healthy communities. Please reach out to me if you're interested in learning more about how you can help us advance the White House conference goals and commit to ending hunger and building healthy communities. So without question, as we talked about earlier this morning, COVID brought to the forefront how too many individuals and families in our great nation do not have access to healthy, affordable food. And at that same time that we were seeing the impacts of food insecurity, researchers also estimated that nearly 2/3 of COVID-19 hospitalizations in the US were related to diet-related diseases, including obesity, diabetes, hypertension, and heart failure. And one of the most disturbing aspects of the COVID-19 pandemic was the disproportionate harm that it caused to historically underserved groups. In fact, studies have found that COVID-19 pulled down the life expectancy for the Latino community by nearly 3 years. And while disparities in food insecurity and diet-related diseases were highlighted by COVID, This group knows very well how these are long-standing problems that are associated with decades of structural inequities in education, employment, housing, among others. So over the last 2 years, the USDA has been working to transform policies, programs, and practices in ways that have the greatest potential for ensuring equitable access to healthy, safe, and affordable foods. We were also working to build awareness among our staff and key partners about the sizable body of research indicating that structural racism harms health in ways that can be described, measured, and dismantled. This work includes having each of our agencies across the department develop equity plans. And it also includes the establishment of the first USDA Equity Commission. So I won't go into detail on these bullets here, but you can see our list of accomplishments so far. And again, we have a lot more work to do in light of the challenges that we've discussed this morning. But we are proud of our efforts thus far to accelerate progress on equity through the USDA. So as Secretary Vilsack explained in launching the Food and Nutrition Security Initiative a little over a year ago, we are leveraging all of our assets to support moves towards healthier eating patterns in an equitable way. And we need your help. The medical community and each of you here today are trusted messengers. By working to enroll all eligible individuals into our programs, you can help us advance our efforts to undo structural inequities to accessing healthy foods. Since launching our Food and Nutrition Security Initiative, the USDA has come to define nutrition security to mean consistent and equitable access to healthy, safe, affordable foods essential to optimal health and well-being. And there are two core motivations for this evolution. The first is the promotion of health equity, which means everyone has a fair and just opportunity to be as healthy as possible. The second is the recognition that structural inequities make it hard for many people to eat healthy and to be physically active. Using our four-pillared approach here, we aim to provide meaningful nutrition support throughout all stages of life, as we did with the reevaluation of the Thrifty Food Plan to bring SNAP benefits more in line with the cost of eating healthy. We also aim to connect all Americans to healthy, safe, and affordable food sources through programs like the Gus Schumacher Nutrition Incentive Program, or GUSNIP, which supports organizations like Hispanic Health Council in Connecticut and their produce prescription program geared towards Latina mothers. By a raise of hands, how many of you are familiar with GUSNIP? So it's an exciting program, and we could talk more about this after today's session, but it essentially integrates or connects the food system with healthcare systems. This program was created in the 2018 Farm Bill. So we have lots of key findings from year 2 of this program, but again, it's another opportunity to leverage this resource to connect food systems and food system players with healthcare system players as well. So going back to the four-pillared approach, our third pillar is around collaborative action, where we are looking to connect, we're also working to develop, translating, and enacting nutrition science through partnerships, like the Dietary Guidelines for Americans that's currently being updated, and that's another opportunity for you all to engage in the DGAs. They have meetings, and you could submit comments online, and this is an important opportunity to help elevate the Latino voice in this process as the DGAs inform our policies and programs across our agency. And last but not least, equitable systems. We're also working to prioritize equity every step of the way, including our efforts to bridge language barriers to nutrition education resources and recipes as well. So the day after the historic White House conference, the USDA released this report, which you can also find online, that talks about how we are leveraging the momentum of the White House conference to advance food and nutrition security. And throughout this report, we emphasize how our partners, and each of you here today, are a critical ingredient to get us there. I want to draw your attention to how your help improving our program utilization can help us advance food and nutrition security. So I'll start with SNAP, which is the nation's largest federal nutrition assistance program that reaches more than 41 million Americans each month. SNAP has been shown to significantly reduce healthcare utilization for those living with chronic conditions who are income eligible and who are food insecure. However, nearly 1 in 5 persons eligible for SNAP in fiscal year 2019 went unserved in an average month. So there's some gaps there that we need to address. Next up is WIC, which is a program that's, I know it's near and dear to many of our hearts. So WIC is nearing its 50th anniversary, and this program is widely regarded as one of the nation's most effective public health nutrition programs. Research shows that WIC reduces healthcare costs and increases preventative care and immunization rates among children. About half of all infants in this country participate in WIC, and nearly 40% of those who participate in WIC are Latino. But the program is underutilized, and we need your help promoting participation and retention. I also want to highlight the power of school meals. So each day, the National School Lunch and Breakfast programs provide nutritious meals for around 30 million children across the country. And research indicates that the meals students receive at school are shown to be the healthiest foods they eat all day, and school meals have been shown to establish healthy eating patterns early. Participating in our school meal programs has also been shown to support academic performance and attendance as well. And that's one of the reasons why we are expanding Healthy School Meals for All, which is our #1 priority for the White House National Strategy on Hunger, Nutrition, and Health. So over the past decade, the strides made in school nutrition show that healthier school meals are possible when everyone who plays a part, school nutrition professionals, parents, students, school meal partners, and the food industry work together. And this also includes the medical community, promoting participation in school meal programs. I did want to highlight that currently we are in the process of, we've proposed updates to school meal nutrition standards, and there's an open public comment period that's running through May 10th, so I encourage you all to engage in this process to inform our next steps. Next up, I want to talk about our healthcare summits. So one of the priorities that I wanted to lift up from the national strategy that I mentioned earlier was our efforts to better integrate nutrition and health. So a few weeks after the White House conference, we hosted a National Nutrition Security and Healthcare Summit at the USDA's headquarters in Washington, D.C. It was an exciting opportunity to speak to healthcare plans, hospital systems, pediatricians as well, about the importance of integrating nutrition and health. The goals of the National Summit were to celebrate and showcase what the healthcare sector is already doing to help advance nutrition security, identify existing and potentially stronger intersections with USDA's equities, inform government and policy leaders, healthcare leaders, media, and the general public about opportunities for strengthening the intersections between federal nutrition assistance programs and the healthcare sector. So currently, ProMedica and the Root Cause Coalition are hosting 7 regional summits across the country. So far, they've held 2 regional summits. The next one is being held in Worcester, Massachusetts on June 1st, with more to be determined later this year. But please reach out to me if you'd like to learn more about these summits and ways you can engage in these opportunities. I'm very mindful of time, so I'm just gonna pivot over to key takeaways. So what can we do today that will set us up for success to advance food and nutrition security in the long term? Here are a few action steps you can take. 1, you can help us promote and champion our suite of federal nutrition assistance programs that have been found to reduce food insecurity, reduce healthcare costs, and improve health outcomes. You can also raise awareness about the importance of our programs like SNAP with state, local, federal, tribal, and territorial leaders. Share your story, your experiences in helping to connect families with nutrition assistance programs. Collaborate with partners with community-based organizations that provide nutrition assistance to ensure that we reach all those that are eligible for our programs. And share your stories and experiences with us. If there are questions or concerns you have about our programs or what you're hearing from your patients, please reach out to our team, please reach out to me, and I'd be happy to talk further with you all and your partners as well. Because we know that the Latino voice is vital to ensure that all of our children and families are able to thrive. And if there are any upcoming conferences or meetings where you'd like for us to present about our work, please feel free to let us know as well. So again, I want to just thank you all for the incredible work that you do every day across the country to keep our children and families safe and healthy. And let's give our panelists a round of applause for their incredible work. So with that, I think we're going to turn it over to Q&A from the audience.
Yes, hi. Thank you very much, all of you, for your performance today to tell us all about Medicare, among other things. I am Mary Ann Ramos. I'm also a physician assistant associate and very interested in Puerto Rico, especially for Medicare. Now, tell us, if you would, about the disparity of the Medicare payments to the providers in Puerto Rico. And one of the problems is that many providers have left Puerto Rico. So there's just not enough physicians, PAs, nurse practitioners to go along. And in fact, we're working on legislation for the last two. So please, if you would, Ms. Saal-Ridpath, would you address the problems that we are having or have seen in the last 20-plus years of disparity of Medicare?
Yes, absolutely, and thank you for that question. You are correct. There are many shortages among the healthcare providers in Puerto Rico as well as elsewhere throughout the United States, and it is something that is a big priority for not just on the Medicare side, but across the healthcare system. And so there is a lot of work going into how do we address the workforce shortage issues. And so specifically speaking to Puerto Rico, as you know, Medicare Advantage, there is a high penetration rate in that area, and so a majority of Medicare beneficiaries are in Medicare Advantage. And we are continuing to work each day to really try to close those disparities, and so really leveraging some of those key components of the Medicare Advantage program where we can bring in care teams, so not just physicians, but others like PAs like yourself and others to really try to deliver that care despite some of these shortages. But it's certainly an issue that's, it's impacting everyone, and there is a lot of work underway at both the state and federal level to try to address some of those challenges.
So if I didn't put the question correctly, is it true that Puerto Rico's Medicare is like given 25% versus 100% in the states and other territories?
I don't recall the specific numbers, but I do know just how the payment system works. There are some differences among the areas because it's developed on a county-by-county basis. And so really just trying to work to identify where those opportunities lie to improve that and close that is definitely something that I know many representatives from the area are interested in doing, and also they've introduced some legislation around that.
So I must not still have given the right question. 20-some years ago, maybe 15, somebody in our U.S. Congress said, well, Puerto Rico, we'll only give them 25% of Medicare benefits. Mm-hmm. Is that still true? Forget that, they're looking at different little, yeah. The difference is, I think, bigger than just community difference.
Yes. I don't know specifically what that difference is.
Okay.
I can certainly check for you.
Thank you very much.
Yes.
I wish you did. Thank you.
Thank you for your questions. Yeah, just really quick, I will say that the Biden administration has increased funding to go to Puerto Rico to help with these disparities that we're seeing, not only with traditional Medicare, but also with Medicare Advantage, because almost the entire island population of beneficiaries is actually on Medicare Advantage. So we're working to improve that. We have time for a couple more questions. Oops,
Can I interject in the subject of Puerto Rico? Because I heard testimony from a very, from the legal aspect that there was a big ship that actually landed there with a lot of providers and ready to meet their needs, but when the people arrived, they were turned away because they had strict requirements for them to even obtain health. So are you listening to the constituents? Are you listening to, do you have town halls so that you can assess what the needs are directly?
Yes, thank you for that question as well. We are expanding our efforts to go into more the local communities to hear those voices. My organization, we are a national organization, but we are expanding our footprint on both the state and local level so that we can collect these stories to better inform our policy as well as our research. And so I do appreciate that comment, and we'll certainly bring that back.
Last question, can you give an example of an organization that you walked through the research evidence-based with the outcome of their data collection being turned into and endorsed for evidence-based practice?
A specific example of research that builds that so that we can then develop.
Well, you said that you would reach out to organizations, Hispanic organizations, that then you would walk them through the research and evidence-based practice. So I just wondered if it's diluted or if you collaborate with them, walking them through the process.
No, it is a very collaborative effort, and that partnership looks different for every type of organization. And so, again, we're an allied organization that wants to hear all voices and have that level of engagement. And so, again, we would appreciate those opportunities to work with you all.
Hi, I'm Dr. Teresa Ramos. I'm a regional CMO for Cigna Medicare Advantage. So thank you, Kaitlyn, for being here. My question is, there's a lot of buzz in Washington to get rid of Medicare Advantage, and your presentation was saying we're growing, we're continuing to grow. It's going to, it's going to continue to grow. But what's happening in D.C. that says otherwise?
Yeah, I think as a program continues to grow to then soon become about half of the Medicare population, there is continued and increased interest on what's happening there. But we firmly believe there are always opportunities to improve and strengthen a program, and we are working to do just that. We had a series of more recent regulations that work to improve consumer protections, as well as expand some benefits and make access to care, improve access to care for beneficiaries. And so we are working closely with our stakeholders, including policymakers, to really identify those opportunities to continue to make it the program it was created to be, to deliver that high quality care.
Thank you.
Okay. Thank you all for your very informative presentations. My name is Dr. Lavon Ortega with the CDC, and I have a few questions. First for Dr. Luna. This slide that you showed surrounding the life expectancy by race, ethnicity, have you all broken that data out by sex as well to see, because I would imagine that there's some impact based on the sex of decedents, so males versus females.
Yes, we have. We have our dashboard, everything that I just mentioned here. We have our atlas from the city of Chicago. I can share the link later on, right? It wasn't shared there. But we do have a dashboard. We just recreated and revamped the COVID-19 dashboard. It has by gender, it has also ethnicity, it has by age, and it has two of them together, like by age and ethnicity. So you can grab a lot of information, how disproportionately affected it was.
And were there any recommendations that came out of that from what you all saw for Hispanics as well as Black African Americans?
All our strategy is based on that. Like everything that you saw, and what we call the COVID and Community Vulnerability Index is taking into account that devastation. Particularly, funds are deployed to those areas as we see there. So everything has been built there that way. Protect Chicago Plus was one of the programs that we had and deploy there, canvassers, promotoras de salud, every single model that we know that worked and it was no longer in place, we brought back to Chicago. And not only Chicago, but our allies, organizations come to round up because, financial is a huge issue here when it comes to the public health and all the health departments for that reason. So every strategy that we have. Our care model, 911, is deployed to exactly those communities where we see our highest crisis. They're all Blacks and they're all Latinos. So our money from the Department of Public Health goes particularly to those communities that need it the most.
Yes, thank you. And I just have one quick comment for Mr. González and Charmaine. I think coming from a federal agency myself, I think one of the things that I often wish could happen more is that agencies across the federal government, that we would collaborate more and identify ways to leverage one another's work to solve these larger sort of complex issues. And so as, you know, hearing both of your presentations, I thought about the challenge with regards to women and the disparities within the labor force with regards to pay equity and the issues you raised, and then Mr. González, the challenge with regards to getting fresh, healthy food to minority communities. And so again, thinking about ways that we can leverage one another. Are there innovations between USDA, the Department of Labor, and maybe even the Small Business Administration that isn't here today, but through those collaborations, we could begin to make some significant impacts in these areas. Thank you.
Thank you for your question. There is work, conversations being done between USDA and HHS. I'm very mindful of time, so I think if our two last participants can provide very quick questions, that'd be great. And then we have remarks by Dr. Rios as well.
Just an announcement.
Yeah. Good morning. Luis Estevez. I'm a physician who was trained in preventive medicine, public health. I was a former board member and first chairman of the board of NHMA. My current job is with a health plan, and we are looking at, actually they not only have a division of equity and inclusion, but they just started a division looking at the social determinants of health and a position. There's a lot of funding available, and I want to know sort of what is the evidence that backs up some of the comments, because they're only going to fund those evidence-based models. And there's both corporate funding and there's foundation funding, and we're looking for a target. And it's not just for health plan members, it's for, in this case, all of the country. So could you address where can I get local evidence-based data that backs up some of the interventions to address the social determinants of health needs?
I could share one example. So actually, I spoke at a conference, at AHIP's conference last month, and Kaitlyn was there as well. And we had a presentation by Mom's Meals that talks about how they were able to work to provide fresh produce, fresh fruits and vegetables to individuals with chronic health conditions. And she presented on some of the results from their demonstration projects. But it involved partnerships with health plans, with other systems, and then with these services, these anti-hunger services. So there's some examples out there. I think across the country there's a lot of exciting work happening to connect, to support the integration of nutrition and health. And I think there's a growing conversation on food is medicine. Within our healthcare summits that we host, also it's an opportunity. But there's very localized examples out there. I think there isn't there isn't one solution, I would say, but I think this is an exciting moment to learn from each other and to uplift what are some examples out there that can be replicated. But that example comes to mind from Mom's Meals. I could send you that information that demonstrates some of the key findings that could support what that might be of use or informative for health plans to consider in terms of what makes sense to address, what would work well in terms of meeting your bottom line, what works well to reduce and improve health outcomes for the patients that you serve as well. Yeah.
We'll talk after.
Lupe.
Good morning. First of all, this panel was amazing. Great job for the presenters. I had two questions, and one was addressed to Dr. Luna. Being the first Latina, I guess, director for the Department of Health for Chicago, one issue that I see in terms across the country, and COVID really exposed it even more, is the lack of minorities in the public health space. And I was wondering what initiatives or plans you had to increase the representation of minorities in the public health arena. And I think you have a lot of data that can support that effort, and maybe partnering with universities that have programs and masters in public health could be one approach to create that pathway. So.
Yes, and this is very important. It's kind of shameful that I'm the first Latino in 2020 to join the Department of Public Health. But we know there's a couple of strategies that our department has created to try to better that. We just put together a bureau that it's called Equity, it's IDEA, Inclusion, Diversity, Equity, and Access, where we're embedded, revamping internally the message to view, values, principles, everything that has to do with sensitivity, cultural sensitivity, and most important, like how to treat our community's identity, and that is reflected externally in our message. We have pipelines, individuals from school, teaching from high school, all the way up for people graduating, doctors graduating, and residents rotating through the Department of Public Health, and we're putting a lot of effort on that. We need policy changes. We need more money coming to give our medical directors, our team, our healthcare providers, because they just go. It's a revolving door, and this is a huge problem that CDC acknowledges, and we've been surveyed to check on burned out and to see what can be more appealing to not only attract, but enhance and retain our faculty, our staff there. So there's a lot of work in there. We try to flexibility. We're working on is telework to see how we can be more appealing to our communities of minority communities in this case. And most importantly, this legislation needs to change, but from everywhere. We need to put more effort in training our minorities to treat our patients, because we know that cultural and language concordancy and competency makes a huge difference in health outcomes of our communities. COVID demonstrated it, so completely agreed.
So I'm sorry, we are at time, so we need to,